Okay, dear students, so today I'm going to teach about cutaneous bacterial infection, one of the very important topic in dermatology. And from the clinical point of view also, a lot of cases would come to the hospital because of these problems. So under this topic, we are going to talk the classification first, primary pyoderma as well as secondary pyoderma, followed by others, common cutaneous bacterial infection. Now, primary pyoderma are classified as folliculitis, furuncle and carbuncles, impetigo, erysipelas, cellulitis, and SSSS means staphylococcal scalded skin syndrome. Now, we are going to discuss all of these one after other. About the secondary pyoderma, bite wounds, okay, bite wounds can be caused by animal bite, can be caused by insect bite, or can be caused by human bite as well. Now these are contaminated with a lot of bacteria. That's why there is high chance of secondary pyoderma. Infections of the burns, wounds, or underlying dermatitis is another common cause. Like burn is a very common problem all over the world. And whenever the burn patient is admitted to the burn ward in the hospital, secondary bacterial infections are quite common. And these are nosocomial infection, most commonly caused by Pseudomonas, Staphylococcus aureus, which has MRSA strain, as well as other gram negatives. Diabetic wound infection, very common. Diabetic, okay, or diabetes mellitus is an immunocompromised condition. So wound infection is very common because of that. And one more thing, if any wound occurs in diabetes, it takes a long time for the healing process. Long time. Okay. Decubitus ulcer, also known as pressure sore or bed sore. Now, in which type of patient these decubitus ulcer or bed sore develop? Now, think about situation. If those patients cannot move their body for a long time, they are in one position for a long time, like paralyzed patient. Okay, this is a very good example. Paralyzed patient. In them, decubitus ulcer or pressure sore can occur in dependent area of the body. I mean, in those areas which are all the time in contact with the bed or any other surface. Surgical wound infection, especially during surgery, if a proper precaution is not taken, proper sterilized instrument are not used, okay, then there is high chance of wound infection. Any surgery can be the example during that regard. Now, let's enter into the topic proper. Folliculitis, furuncles, and carbuncles. Now, what are these? These are three different degrees of, okay, these are three different degrees of severity of staphylococcal infection occurring around the hair follicle. Now, hair follicle is a common thing here, and these occur around the hair follicle. Now, folliculitis is the most simple type of infection around the hair follicle, or it is the mildest one, we can say. It's a simple superficial infection around the hair follicle, which is rarely tender. So you can say it's an early inflammation there. Furuncle is a slightly severe than that. It's a small collection of infected material around the hair follicle, and it is very tender now. Already there is a pus formation, okay, in connection with hair follicle, and it is very tender to touch. Now, one of the common area for furuncle to develop is around the nasal orifices. That area is very rich in hair, and furunculosis is very common. Furunculosis means multiple furuncle together. Now, that area is also known as danger area of the face, the upper lip and around the nose. So, do not squeeze furuncle if it occurs in that area. It can easily, get into the central nervous system through emissary vein. Those emissary vein are connecting extracranial vein with the intracranial vein. Carbuncle. When several furuncle become confluent into a single lesion, this is called carbuncle. Means several furuncles are connected with each other, okay, and there forms a bigger lesion. Now carbuncle is extremely tender. Okay, let's move on. Now let's talk about furuncle. Now furuncle, okay, the common site of furuncle are face, buttock, thigh, groin, breast, and axillary area where there are hair follicles present. And this furuncle is also known as boil, okay, boil, B-O-I-L, boil, uh, as its synonymous term. That is also very commonly used term in clinical practice. Now look at this picture here. Look at this picture. This is hair follicle, okay. This is a sebaceous gland which is attached to the hair follicle, okay. So there may be pus formation somewhere here in relation to the hair follicle in case of furuncle. Now, what are the signs and symptoms of furuncle? It is small in size, usually less than 2 cm. It is raised from the surface, very tender. It is edematous, okay, and shiny, and it looks bright red or erythematous. All the signs of inflammations are present there, okay. It causes a lot of pain in that local area, that is intense and throbbing pain. And one very important point is there is a pus point we can see. Sometime it ruptures on its own and the pus will be discharged, and it will get better after that, okay. If it doesn't discharge on its own, we can help it to rise. Now ripe, I should say, sorry, ripe. Now we should help it to ripe. Now what is the way to do that? One way is we do hot fomentation. Now hot fomentation means you apply some heat onto that lesion so that pus will be localized and pointed at one area, so that drainage of the pus will be very easy. And this is the treatment in case of furuncle. Now what about carbuncle? This carbuncle is a confluent infection involving multiple contiguous follicle. You already know this definition. Multiple furuncles are fused with each other. They come in contact with each other. So in one area, a big looking infected area is formed. That is carbuncle. It is mainly limited to the subcutaneous tissue, and it is basically a localized skin abscess. So we can consider this as a type of skin abscess there, because it is very severe condition. Now look at this picture here. Okay, this is important one for you. Now share. This is one of the favorite area for carbuncle. Okay, the back of the head. Okay, you can say the upper part of the neck on the back side. Now if you see very carefully, there are multiple openings you can see. Okay, I can clearly see 1, 2, 3 and 4 opening here, even 5 here. So these are different furuncles, okay, which are combining together to form a big carbuncle lesion. This is carbuncle. Now here is another one, okay, this area, look at the, okay, a little bit pus point here. These are individual furuncles. Now what are the common signs and symptoms of carbuncle? They are present on the back of the neck or torso. Torso means body, so they can be found in the back of the body as well. Pain, swelling, and induration of the surrounding skin is a very important feature, because this is infection. Okay, and most of these infections are caused by Staphylococcus aureus. So there will be pain, swelling, and induration of the surrounding skin. Induration is caused by edema of that part of the skin. If I feel that indurated area, it feels very firm to hard. Now multiple small abscesses occur with yellow thick pus. Okay, this is pus, please correct the spelling, P-U-S, pus. Okay, multiple small abscesses are there inside the carbuncle, which may be separated by septa, individual septa, and there is yellow thick pus there. Now, fever is a very important feature because it's a complicated infection. Fatigability, leukocytosis, and even septicemia can happen. Now, septicemia easily occur if the person is immunocompromised, like diabetes. Now, how to manage folliculitis, furuncle, and carbuncle? What are we going to do? Now, I already told you we have to mature the lesion first, especially in folliculitis and furunculosis. That is a very important part of the management. Do not squeeze it. That is not going to help. Okay, allow it to mature or do something which allow it to mature. Now, one of the important step here which I like to highlight is called hot fomentation. Now, this hot fomentation means application of heat onto that lesion so that it will get mature, or pus would be pointed so that it would be easy to remove. Another way is surgical incision and drainage. This is important one. Okay, surgical incision and drainage. Now, if large and deep, okay, if a carbuncle is large, then what should we do? Then we give cruciate type of incision on the surface. This cruciate incision is a cross type of incision, okay, or plus type of incision, whatever you want to say. uh, it it opens the wound completely, and we have to insert our finger there, and we have to break all the septa which are separating each of these furunculosis, because in other words, it is also considered as a big abscess, and inside that big abscess the multiple small abscesses are there which are separated by septation. So we need to break those septa, then only all the pus can be drained properly. After that, you can put a drain there, or you can put the gauze pieces. But remember, you need to change those gauze pieces almost every day and check how much pus is coming from the drain. After a few days, you don't need to do that again. Now, another important step, because this is a staphylococcal infection, so antibiotic has to be given either locally or systemically. Now, folliculitis is a very benign or the mildest of the infections. So even local antibiotic would be enough, like mupirocin, and one more is called fusidic acid. Okay, mupirocin and fusidic acid. Okay. So let me write it here. These are very important knowledge for you in relation to the practice. Now, these are anti-staphylococcal substance, so they really may help. For furuncle and carbuncle, we use systemic antibiotic, either given orally or intravenously. Now, penicillin, mainly anti-staphylococcal penicillin, like cloxacillin, flucloxacillin, okay, nafcillin, they are mainly used. As cefadroxil, the second generation cephalosporin can be tried. Erythromycin can be tried, and even clindamycin can be tried. Now, look at this picture here. This picture is clearly tell us how to do incision and drainage in case of carbuncle. Okay. See here. Look at this lesion. Okay, this is called cruciate incision. So a cruciate incision will completely open the carbuncle. Then we can insert our finger there. We can break all the septation. Okay, turn that into one big cavity. Put a drain or put the gauze pieces. Remove all the dead and devitalized tissue from there. This is very important one. Otherwise, infection is not going to be settled. After that, give antibiotic in a very good dose, and um, every day change that gauze piece, or check if you have put the drain, check how much secretion or pus is coming out from there. This is the management of carbuncle. So it is almost managed like abscess. Okay. Now another important infection in relation to the skin is impetigo. What do you mean by that? Impetigo is a superficial bacterial infection of the skin which is largely limited to the epidermis, and it is not spreading below the dermoepidermal junction. So it is very superficial infection of the skin. Only epidermis is involved. Okay, it will not cross the dermoepidermal junction. Now there are two basic or classical forms of impetigo: non-bullous type and bullous type. Now, we all know what is bulla. Bulla is a blister. Okay, it is larger than a vesicle or pustule. Okay, and it is filled with fluid. So bullous impetigo and non-bullous. Now bullous impetigo is mainly caused by Staph aureus, whereas non-bullous impetigo is mainly caused by Streptococcus pyogenes or group A beta hemolytic streptococci. Now regarding the non-bullous impetigo, you can see the picture here. Okay, this is non-bullous. More than 70% of the cases are non-bullous impetigo. So this is more common than the bullous variety. And in this case, the lesions typically begin on the skin of the face or on extremity that have been traumatized. So like this, okay, on a healthy skin also it can start, and sometimes even the traumatized skin it can start. In the beginning, a tiny vesicle or pustule is formed. Vesicle means a small blister less than 5 millimeter in size which has got clear fluid inside, and pustule is same type of description but pus inside. Now it rapidly ruptured and lead to crust formation. Now this crust is called honey colored crust. Now this honey colored crust is very typical of impetigo, and this is usually less than 2 centimeter in diameter. So remember, honey colored crust after the lesion ruptures. Now let's see some of the different pictures here. See this? Okay, these are the different impetigo lesions in adult. These are in the children. It is very common in children. Typical honey colored crusted lesion on the face and near the angle of the mouth. Now, this is another one, slightly bigger in diameter, but again impetigo, very superficial skin lesion. Now, what are the differential diagnosis of impetigo? Now, one of the commonest differential diagnosis would be viral infection, mainly caused by herpes simplex virus type 1 and varicella zoster virus. Varicella zoster. Okay, what is the which disease is caused by varicella zoster? Nice, it's chicken pox, isn't it? We all know that. Chicken pox can have polymorphic type of rashes, so they can also rupture and lead to similar type of condition. Fungal. Strictly speaking, this carrion is a Tinea capitis. Okay, Tinea capitis, and Tinea corporis is the body fungus caused by dermatophyte. So they can be considered as a differential diagnosis if this carrion is occurring a little bit, anterior part of the scalp. Sometimes it may be, it may be a little bit coming down toward the face. Now, parasitic infestation caused by scabies and pediculosis can be considered. Uh, they can be secondarily infected by the bacteria, and it may look like the same. Now, what is bullous impetigo? Now, this bullous impetigo, you can see in the picture, the bulla has been ruptured now. Actually, I cannot see the bulla, but usually patient may present like this also, because by the time they come to the hospital, the bulla is already ruptured. So this is mainly caused by Staph aureus, and this is the infection of infant and young children than the adult. Now, these are the picture. Okay, see here, these are the different bullous impetigo. Some of them are already ruptured, some are also ruptured, but I can still see the scab or crust on the surface. Another picture. Okay, now bullous impetigo consists of flaccid transparent bulla which develop most commonly on the skin of the face, buttock, trunk, perineum, and extremity. Again, more common sites are the trunk, that means the limbs, or even the face. Rupture of bulla occur very easily because they are quite flaccid, and then even in neonate, the bullous impetigo can occur. It may begin in the diaper area. Okay, diaper area. So parents should note that. You see this? This is a diaper area. See, it's a neonate diaper area on the medial aspect of the thigh of this big bulla. You can see the edge of the bulla. It is already ruptured, but I can still see the edge. So this is called bullous impetigo. Another one, okay, and the extremity, a big bulla is there. Now a lot of crust still can be seen. Now these are on the anterior surface of the tibia. Okay, this is on the foot. So all of these are important points. Now what are the differential diagnosis, okay, of these impetigo in bullous impetigo? In neonate, herpetic infection and early scalded skin syndrome can be considered. Both of these herpetic infection can lead to vesicle formation, or sometimes even if those vesicles are infected, pustule. And early scalded skin syndrome, again, okay, there will be a few vesicles, few blisters, but later on they are completely ruptured, and more extensive skin surface is involved in scalded skin syndrome. It is also caused by Staphylococcus aureus. Now, in older children, allergic contact dermatitis, burns, erythema multiforme, pemphigus vulgaris, and bullous pemphigoid can be considered. Now, all of these are associated with either vesicle or bulla. Now, allergic contact dermatitis, it may be associated with vesicle or bulla, but more commonly is the rash there. It's an itchy type of rash. It's a type 4 hypersensitivity reaction, which is caused by contact of some of the substance there. It may be watch, okay? It may be ring, it may be jewelry, okay? It may be some cosmetics. These are the different examples. Burns, we all know in secondary, okay, type of burns, a little bit deeper burns, but not that deep also. Second degree burn, I should say, rather than secondary. There will be blister formation. Erythema multiforme is a drug reaction where target lesions are formed. These are also known as bullseye lesion, mainly caused by drug reactions. Sometimes can be caused by viral infections as well. Pemphigus is an autoimmune skin disorder where there are formation of blisters and vesicles. And bullous pemphigoid, it's a bit similar to pemphigus, but the bulla are deeper. Okay, they are deeper. They are formed in dermoepidermal junction in bullous pemphigoid, whereas in pemphigus they are superficial. So by the time pemphigus patient comes to the hospital, those bulla are already ruptured, but bullous pemphigoid, a bulla is still there. Now, some of the complications which can occur after impetigo are a nephritogenic strain of group A beta hemolytic streptococcus can lead to PSGN. If this bacteria, okay, has caused the infection, that means the non-bullous type, then PSGN can occur in that child or in that adult. Now, one important information I like to give, maybe many students know already, okay, this particular bacteria, group A beta hemolytic streptococci, can cause two important type of infection, rheumatic fever and PSGN. But remember, only throat strain or pharyngitis strain can lead to rheumatic fever. Okay, the skin strain or pyoderma strain never leads to rheumatic fever, whereas the PSGN can be caused by both strain, okay, pharyngitis strain as well as pyoderma strain. Now, very rarely, osteomyelitis, septic arthritis, pneumonia, and septicemia can be a common complication in case of this disorder, because this is an infection that infection may go to other organ and can lead to this complication. Now, what is the treatment? Okay, you can use some local antibiotic or local treatment in the beginning, like mupirocin or fusidic acid. Mupirocin or fusidic acid, they can be tried. See there, mupirocin and topical fusidic acid. They are good medicine in the beginning if the lesions are not that complicated. They are applied 3 times daily for 7 to 10 days. But we don't say these cutoff duration. It depends how the patient is responding. Oral erythromycin can be given in a bit of serious or complicated infection, again given for 7 to 10 days. And systemic therapy with beta-lactamase resistant oral antibiotic, also known as anti-staphylococcal antibiotic. Again, same example can be given: cloxacillin, flucloxacillin, okay, napcillin, as well as amoxicillin with clavulanic acid combination can even be tried. Now, after discussing this impetigo, let's talk about erysipelas, another common skin infection. Now, what do you mean by this? Erysipelas are caused by, okay, erysipelas are caused by beta hemolytic streptococci and very rarely by Staph aureus. So this is one important point here. And which area of the skin is infected, it is even more important. It involves here both epidermis as well as dermis, and it predominantly affects the lymphatic channels in the dermis. This is a very, very important point. Both epidermis and dermis are involved, and it also affects the lymphatic channel in the dermis. As a result of this, okay, there will be slight edema at that area, and that edema leads to induration of the lesion. That induration is a hallmark of erysipelas. We can describe it as a superficial cellulitis. Cellulitis is a deeper infection. It is mainly infection of the subcutaneous area, whereas erysipelas is considered a little bit superficial type of cellulitis. Now, clinically, it is characterized by intense erythema or redness, induration, it feels hard or firm, and it has a sharply demarcated border because it is slightly elevated from the surface because of edema. So we can clearly see the border, okay, which is separating the normal skin. Now let's see here. This is the lower limb, isn't it? We all know that this is tibia. So in this area, the swelling and redness I can see, and in this patient, it's right here. So these are erysipelas, and 70 to 80% of erysipelas occur in lower limbs. Now, face is another common site for erysipelas. This is a very, very typical lesion, okay, and one of the favorite picture during the examination from the teacher side. See here, this is elevated from the surface, okay, it looks very red and it is sharply demarcated. This is erysipelas. Now let's talk about sign and symptoms of erysipelas. Now fever is there because it is slightly deeper type of infection than impetigo, so fever is usually present. Dermatological sign or skin signs are there, like it is very painful, it is erythematous or red in appearance, and it is edematous rash which is elevated from the surface. It has sharply raised border with abrupt demarcation from the healthy adjacent skin. You can you have just seen that picture on the face, exactly that, okay. So if that picture is shown to you, don't hesitate and say it's a case of erysipelas. Now lymphangitis is an important feature of erysipelas. Because of this, there is irregular extension from the center of the lesion, because these lymphatic channels are going here and there, isn't it? So if infection is spreading through the lymphatic channel, then these irregular type of extensions are quite common. Desquamation can occur from the surface. This is we lose certain covering from the surface, or flecking can be formed. Vesicles, okay, can occur on the surface again, and lymphadenopathy. This is a bacterial infection. Remember, the regional lymph nodes will be enlarged, and they are tender as well, enlarged and tender. Now, this is another picture which is telling erysipelas, sharply raised border. Okay, see this sharply raised border with abrupt demarcation from the healthy adjacent skin. It is also here. So this is a healthy skin. Okay, this is healthy skin. It is healthy skin right here. It is also healthy. There is a sharply demarcated border which is separating the lesion from the healthy skin. Erysipelas. Now another picture. This is here on both sides. So painful rash, red looking rash, and edematous rash. Erysipelas. Remember, epidermis and superficial part of the dermis are affected. Now, how we manage this condition? So antibiotic play a big role, and they should be prescribed as soon as possible. And the common antibiotic we choose are penicillin, erythromycin, and cephalexin. Anyone can be your choice, because the common organism is Streptococcus pyogenes. Symptomatic treatment are very important. Okay, the patient is having fever, so antipyretic, and the choice is paracetamol, and analgesics, NSAID. Okay, any type of NSAID can be given. Even paracetamol can act like an analgesic drug. Hydration, if the patient is dehydrated, or if patient is having high grade fever or look a bit sick, then oral intake is preferred. Okay, we should promote the patient to drink more. Cold compression. Now, cold compression is an important concept here. It decreases swelling, it decreases the pain as well. So swelling and pain are reduced by cold compression, so the patient feels slightly better. But remember, this is not a definitive treatment, okay? This is only symptomatic. Now, some of the complications of erysipelas would be bacteremia and septicemia. Definitely, this is a source of infection in our body. It can migrate from there to other area. Scarlet fever, because the causative agent is same, group A beta hemolytic streptococci, so scarlet fever may occur. And in scarlet fever, there are some typical signs and symptoms. Tonsillitis is the usual feature. Apart from that, there is skin rashes on the body. These are called sandpaper-like rash. Okay, sandpaper-like rash. Let me write some of the important points here. Sandpaper like rashes on the skin, and then it also has strawberry tongue. Okay, strawberry tongue. Now this strawberry tongue is also a classical feature of scarlet fever, but it is not only occurring in this condition. Even Kawasaki disease has strawberry tongue. Now pneumonia. Okay, pneumonia is another important complication. If that infection reaches lung, it can lead to pneumonia. Abscess, it can convert into abscess, or it can lead to abscess in some other part of the body. Embolism, this is called septic embolism, which is more common, but another type of embolism can also occur here. Just think about it. Okay, majority of the uh, erysipelas lesion or erysipelas are occurring on the lower limb. If they are very big, probably the person, okay, doesn't move during that time because of a lot of pain, and because of extensive inflammation, the underlying blood vessels can also be inflamed. This can cause thrombus formation there. Okay, thrombus formation there. That thrombus may turn into thromboemboli. Meningitis, if that infection reaches the meninges or the brain, then in a very severe situation, if it occurs in the limb, Lower limb gangrene may also occur, and the treatment of gangrene is amputation. Now you all know what is gangrene, isn't it? Gangrene is ischemia or necrosis of that part, mainly extremities, with putrefaction. The secondary changes occur after the death of the tissue, that is gangrene. And death can even occur. The cases have been reported, but it is not that very common. Now, another type of infection is cellulitis. Okay, another type of infection is cellulitis. Now, this cellulitis is characterized by infection and inflammation of dermis and loose connective tissue, that is subcutaneous area. Now, if you have paid attention from the very beginning, we have started from the superficial part and we are going deeper and deeper. Now, cellulitis is dermis and subcutaneous area infection. Now, see there is no involvement of epidermis at all. Okay, and it has limited involvement of the dermis. So mainly it is involving subcutaneous area. Now this is one of the picture which is showing cellulitis. Okay, in the lower limb, redness, warmth, swelling, and skin tightness. Redness or erythema. Okay, warmth, isn't it? Warmth, swelling, and skin tightness from the cellulitis. All of these are important feature of cellulitis. Remember, there are no blisters here usually, okay, because this is deep-seated infection. This is very, very important point. Now, etiology are the same organisms. Most of the skin infections are caused by these two organisms, Staph aureus and Streptopyogenes. In neonate, though, we have separate type of organism like GVS or group Streptococci, also known as Streptococcus agalactiae, and even the E. coli are the causative agent. In patients who are immunocompromised, like diabetic, a number of bacterial or fungal agents may be involved. There may be mixed type of organism. Now, there are some high risk factors for the development of cellulitis, and those are obesity, diabetes, poor hygienic condition, intravenous drug use, and immunodeficiency state apart from diabetes. So many others are there. So any of these factors can lead to easy, okay, development of cellulitis. Not only cellulitis, any other bacterial infection can occur. Regarding the clinical manifestation of cellulitis, because it is a deep-seated infection, okay, so area of edema will occur there. We have warmth or heat, redness, and pain, as well as swelling. Edema is swelling already. So all the features of inflammations can be seen on that area. And this is caused by bacteria. So regional adenopathy or lymphadenopathy is quite common, and these lymph nodes are painful. On top of that, constitutional symptoms are also quite common, like fever. Fever is maybe high grade. Chills and rigor may be occurring because cellulitis is one stage before the abscess formation, and even the malaise, myalgia, arthralgia, they may be seen. Now, regarding the diagnosis of cellulitis, it's a challenge. It can be easily confused with abscess, and we should diagnose it correctly. Otherwise, our management may differ. So, what should we do then? The first thing is, okay, examine properly. Just look at that area, okay, thoroughly. Okay, do some fluctuation test. A fluctuation test is positive in abscess, but it is negative in cellulitis. But let me warn you, this fluctuation test may be very painful to the patient, okay, because we are pressing on one side of the lesion and we are moving the content of that lesion so that our other two finger will note that. So in case of abscess or cellulitis it is absent. In case of abscess, it can be very painful experience for the patient. This is mainly done for the cyst where there is fluid inside and no pain. Another one is aspiration. Now this is important. Okay, take a clean or sterilize syringe with needle, clean that area, superficial area of the lesion from where you are going to aspirate, and put the needle inside and aspirate. Now see what type of content is coming. If pus is coming, this is a case of abscess. If only some fluid or some exudate is coming, this is a case of cellulitis. This is an important one. Skin biopsy is not done usually, okay, and blood culture is one of the important investigation, because this is a deep-seated infection. So mostly the organisms are present in the blood. Now, some of the complications can occur after cellulitis, and these are bacteremia, presence of bacteria in the blood, local abscess, definitely it can complicate into abscess. Now, in that situation, the sign and symptoms will be even more. Super infection with gram-negative organism, okay, is that especially occur in inside the hospital or in healthcare setting. Lymphangitis, inflammation of lymphatic channel. Thrombophlebitis, inflammation of superficial vein, very common. Facial cellulitis in children are associated with meningitis in almost 8 to 10% of the time, because they are quite adjacent structure. Infection can easily enter into the brain. And in case of lower limb or even upper limb, gas gangrene can occur. In other part also gas gangrene can occur, but remember, gas gangrene is not the same as other type of gangrene. This is caused by one particular pathogen, Clostridium perfringens, and this is a highly lethal condition. That infection can rapidly spread within few hours, and the patient may die because of sepsis. So the treatment is amputation and antibiotic along with antitoxin. Mortality can be as high as 25% here. But luckily, cellulitis is mainly caused of Staph aureus and Streptococcus pyogenes, so we don't have that type of problem. Now, if in case of neonate, okay, if cellulitis is suspected, full sepsis evaluation should be done. What do you mean by that? It's very important knowledge. Okay, full septic evaluation or sepsis evaluation means I will do complete blood count, okay, with differential count. We'll do blood culture as well. Urine culture should be done. Chest X-ray must be taken, and if necessary, even CSF examination and culture with sensitivity test should be done. This is the whole package. Now for the treatment, we have to choose antibiotics, and these are beta-lactamase stable resistant anti-staphylococcal antibiotics like cloxacillin, oxacillin, napcillin, flucloxacillin. All these are examples. Vancomycin is another choice. If you think MRSA strain of the staph are responsible, or don't take any chance, go for vancomycin. This is the drug of choice. Aminoglycoside can be tried here because they are anti-staphylococcal in nature, and cefotaxime, third generation cephalosporin, also can be given. Even ceftriaxone can be tried. Okay.